Good evening, all. I, Shreya from Torrent Pharma, welcome you all to the Spine series, a noble endeavor by the team of Stavya Spine Surgeons. Thank you all for taking out time from your hectic schedules and joining us live today. Before we move forward, let me take you through the legend of Stavya. Stavya literally stands for Lord Krishna, the first spine doctor in the world. He treated Kubja, a hunchbacked woman from Mathura. The legend says that Kubja was a hunchbacked woman who once crossed paths with Krishna in the lanes of Mathura. She offered him sandalwood paste. Overwhelmed with the devotion, Krishna pressed his foot on her toes and lifted her chin with 2 fingers. It is said Kubja stood straight. The name Stavya has henceforth continued. With similar passion, Stavya stands today, helping thousands of patients lead a better life. The Spine series is an educational effort in the same direction. Today is the 4th webinar of the series for us. The topic for the day is cervical degenerative disease. Sedentary lifestyle, improper diet, improper posture has led to a rise in the cases each day. As these challenges continue to rise, the new possibilities also knock the door. To discuss the same, we have an expert panel with us today who shall be sharing their wealth of experience with us. Before we begin the program, let us all welcome our esteemed moderator for the day, Dr. Shivanand Mai, and our esteemed chief guest for the day, Dr. Pragnesh Bhatt. A warm welcome to you, Dr. Shivanand Mai. Dr. Shivanand Mai is a renowned spine surgeon working currently at Stavya. Dr. Shivanand Mai has a rich experience of more than 17 years. He's an enthusiastic academician and an avid presenter at many conferences. Prior to Stavya, he was an associate professor at KVGMC Mangalore. A warm welcome to you, sir, and I now request Dr. Shivanand Mai to introduce us to rest of the speakers and also introduce Dr. Pragnesh Bhatt. Thank you so much.
Good evening to all. Greetings from Stavya Spine Hospital and Research Institute. Already we have conducted webinars in the past as an educational initiative. In today's webinar, we are going to see mainly on cervical spine disorders. So, disclaimer, it is an educational activity to introduce to the conditions and to increase the awareness about the disease condition and its latest treatment options. And this treatment could vary from case to case. So I am Dr. Shivanand Mais from Stavya Spine Hospital, welcoming you all. Coming to the normal biomechanics of the spine, spine has got good range of movements. So you can see this is the range of movements which we are having. Even cervical spine has got more range of movements compared to the other segments of spine, and it is consist of 7 vertebrae, and the curve is lordotic curve what we have got in the cervical. The unique range of movement compared to the lumbar and dorsal spine can be seen in the cervical spine, mainly the flexion and extension movements, which is good range without any deformation, or this is the unfolding zone. So at the end of the full extension and flexion, there could be some deformation of the neural structures, as we can see here. In flexion there is no deformation, but in extension there is compression due to PID. Are these neck related problems are new to us? No. Since the past days it has been reported about numerous references of neck related symptoms and their elements. So coming to the systematic division of these cervical spine conditions like axial neck pain, which refers along the spinal column and mainly related with the paraspinal musculature. Radiculopathy, it is the radiating pain along the arm, which could be accompanied by sensory and motor changes because of compression of the particular nerve root, and myelopathy symptoms because involvement of the cervical spine and involvement of long tracts in the spinal cord, which consist of mainly walking difficulty and numbness in the hands and legs. Coming to the epidemiology of the neck pain, it is commonly seen in 60% of the adult population, with 5% experiencing very bad pain. And it has been reported that it is common in the people who read more and who had a history of previous trauma. It affects males and females equally, with peak age in males from 50 to 54 years and females 50 to 59 years. The prevalence of neck pain is found to be higher in individuals who are better educated and who have history of headaches and low back pain. The incidence of radicular pain decreases after the age of 60 years. Coming to the natural history, it is a progressive degenerative disorder which leads to circumferential cord compression. So spinal canal protecting the spinal cord is like wolves guarding the goat. So after some times in the elderly people, this spinal canal which is supposed to protect the spinal cord start putting compression on the spinal cord. So with this natural history of cervical degeneration, three types of treatments are available for these disorders. Like axial neck pain can be treated without surgery, no surgery is required. Radiculopathy, if pain is very severe, then needs surgery. And myelopathy, whether it is static or dynamic, most of the time it is unlikely to have substantial improvement, and cases show stepwise deterioration, and most of the cases require surgical decompression and stabilization if needed. So with this introduction, I welcome you all for this webinar. Today, our speakers are from Stavya team, senior surgeons, Dr. Bharat Dave, Dr. Ajay Krishnan, Dr. Devanand, Dr. Ravi Ranjan Rai. And today, we have got a chief guest, Dr. Pragnesh Bhatt, Professor of Neurosurgery from Aberdeen University, United Kingdom. I welcome you, sir, to this webinar. And now I request our today's speakers to go ahead with their talks. Thank you.
A very good evening. Myself, Dr. Devanand. We are going to discuss about the natural history of cervical disc prolapse. So, as you all know, cervical disc prolapse is a condition in which the disc prolapses from its original position to compress onto the spinal cord or the nerve roots. So, what are all the risk factors in cervical disc prolapse? As you can see, male gender, cigarette smoking, heavy weightlifting, professional drivers, those who are operating on the vibrating equipment. These are all the cases, risk factors for the cervical disc prolapse. And younger patients are usually more prone than the older patients because of soft disc, whereas in older patients, the disc desiccates and it becomes a hard disc. So you can have a calcified disc or a cervical myelopathy like symptoms in older patients, whereas in younger patients you have a classical cervical disc prolapse. And C6-7 level is more common than the other levels. In this image, you can see how the cervical spine is getting loaded, the amount of flexion you put it, and as you can see from 10 lbs to it's going up to 60 lbs with the amount of flexion. So we need to avoid this flexion in order to be safe from the cervical disc prolapse and also the neck pain. Not only the regular people, but also the doctors are more prone. As you can see, this 2019 article published in Indian Journal of Orthopedics, it shows that the surgeon's neck posture during spine surgeries is an unrecognized potential occupational hazard, and microscopes, use of microscope, it limits the number of, it limits the neck pain. So you all know the symptoms. The symptoms may be related to spine. The patient may complain of neck pain, medial scapular pain, or the shoulder pain. When there is a root compression, the patient may come with a radiating pain along the arm or chest wall, or the numbness and sometimes weakness. If the patient has poorly localized neck pain, but the generalized feeling of weakness and feeling of instability or imbalance while walking, that is a symptom of myelopathy. You all know that neuronal hyperactivity causes positive symptoms such as pain and tingling numbness. When the patient has weakness and numbness, these are all the negative symptoms. It represents axonal loss or conduction block. So the arm pain typically follows a myotomal pattern, whereas the sensory symptoms, that is burning, tingling, they follow the dermatomal distribution. So on examination, you all know that we need to check for power, grade them, sensation, reflexes. Never forget the distal pulses. Along with that, there are some signs like nerve root tension sign, like we do straight leg raising test. In the lumbar spine, we have a cervical compression or the Sperling test, where the doctor puts force over the head and it bends the neck along the same side of disc prolapse, and it increases the arm pain. So once you are done with the examination, we go for the radiology. You all know that the regular X-rays that are prescribed are AP and lateral views. These AP and lateral views show the pattern of instability or gross cervical images like infection or any trauma, something like that. But few images which you should not miss are dynamic X-rays. Dynamic X-rays of flexion and extension gives a lot of information about cervical C1-2 instability, or if there is any translation in view of subluxation or dislocation or any facetal changes in the dynamic images. These are the special views called as the right oblique and left oblique views. What are these useful for? If you can see, I have put the arrows in the neural foramens. So when you have a patient with disc prolapse, if he has a soft disc or hard disc. So soft disc is a disc prolapse which the nucleus pulposus is coming out through the rent in the annulus fibrosus. But what is a hard disc? Hard disc are osteophytes. So you can have osteophytes from posterior as well as anterior uncovertebral joints, which form osteophytes and compress on the nerve. So these normally we can see in the CT scan, but this is a cheaper way of eliciting it and the better way, where you can see this neural foramens. If there is any encroachment in the neural foramen anteriorly or posteriorly by the spurs or osteophytes, you can diagnose that this patient has soft disc or the hard disc. So next we proceed to the MRI cervical spine. So MRI cervical spine shows us the condition of the cervical disc, whether it is normal, hydrated or desiccated, as well as the disc prolapse. You can have a single level disc prolapse or multi-level disc prolapse. It may be anterior compression as well as posterior compression. In the same way, behind the vertebral body, there is a ligament called as the posterior longitudinal ligament. This posterior longitudinal ligaments also will contribute to the stenotic part or the compression part on the spinal cord, in terms of the PLL may become hypertrophied or ossified. Whenever it becomes hypertrophied or ossified, it contributes to the cervical spinal stenosis, which needs to be identified on the sagittal images. So once you are through to the sagittal images, you go through to the axial images. What does this axial image look like? As the image depicts, there is a disc anteriorly and posteriorly there are spinous process and the lamina. In the center it will be spinal cord, and the disc prolapse can be seen whether it is right or left, and if it is central, paracentral or foraminal disc on this image. So once we have seen the actual images, we classify them. So the classification will be useful for the diagnosing part as well as the communication part and also planning of the surgery. So it is usually classified as a central type, posterolateral type as well as intraforaminal herniation. So after next plan would be management of the patient. When you see the management of cervical disc prolapse, many of the articles have suggested that when these patients are followed with serial imaging, the larger and extruded offending discs are found to resorb the most, and many acute disc herniations are observed to reduce in size as well as symptoms from 50 to 100%. So nearly all the patients, they get better with the conservative management alone. Only few of them require surgery. This is a classical case where you can see that the disc has resorbed over a period of 4 years. So the radiological imaging may take longer time, but symptomatically the patient would be better within 6 to 8 weeks. So if the patient is not getting better or the pain persists even after conservative therapy for 6 to 12 weeks, or when there is a evidence of progression, or if there is any functionally important motor deficit, then the patient may require surgery. So what surgery is to be done, when to be done, what are the ways of doing surgery, Dr. Ajay Krishnan sir would be taking you through. Thank you.
Good evening, viewers. Today, I'm going to talk about the natural history of cervical stenosis. As we all know, our central spinal column is surrounded by the CSF, and all the time it is bathing in the CSF. That's what makes the structure unique. And as we move up and down, as we move the neck, as we move the spine, the spinal cord floats, and hence we do not get the electric shock like feeling or sensation. And when it occurs into the unfolding zone, then it leads to the problem. When it comes into the folding zone, then there is no problem. As you can see here, that this neck movement is occurring to some extent into the limited movement. And whiplash injuries is a classic example. As you can see in this MRI, in the flexion extension MRI is done, you can see the compression increases in the extension, and you can see a lot of changes into the spinal cord as well. This is just an example of one of these patients who presented to us with numbness and imbalance, and he was a male, 55 years. His X-ray looks arthritic, as you can see on the cervical spine, a lot of osteophytes, but in the MRI you can see that this spinal cord, and it becomes tight at the C3, C4 level, and further it becomes tight at the C5, C6 and C6, 7 level. So this patient certainly is going to present with the neurological symptoms and significant imbalance. So what are the classic symptoms of myelopathy? Myelopathy patient comes with spastic gait. It will appear that he is walking on the springs. He has clumsy hands with atrophy of the muscles and also some sensory impairment. And in the later stage, he also presents with the sphincter symptom. And these symptoms we should really ask for, because sometimes patient is unaware of these symptoms, and patient presents to us that patient has normal bladder and bowel, or the habit has changed recently, but he may not have noticed it. So diagnosis is evident with the upper motor neuron symptoms, as we know that patient will have upper motor neuron symptoms in the form of hyperreflexia and brisk reflexes and plantar subgoing. The classic symptoms will be finger escape sign, grip release test, and one can do it 10 times very fast, but if patient cannot do it, then this could be the early sign. Like in this, you can see that the finger escape sign, the lateral finger moves away when patient is asked to hold his hands tight. So these symptoms, they become quite evident along with the Romberg sign. When we ask the patient to close his or her eyes, and then if they start swaying side by side, and if you really put the finger on their shoulder, they will stop swaying. That is the classic Romberg sign positive. The distribution of this will be 75% of the patient will have this distribution of the myelopathy hand sensory symptoms. Sometimes they may present with the hypoalgesia. The diagnosis again is mainly symptoms and confirmed by the MRI and X-ray, and sometimes flexion extension MRI as well. And high index of suspicion is very important in order to diagnose the cervical spondylotic myelopathy. What is the natural history? Once the disorder is diagnosed, once the myelopathy is diagnosed, the neurological function never ever returns to normal, and they gradually worsen. As I mentioned earlier, that there is always some movement that occurs of the spinal cord when we all walk, when we all move, and this compression keeps brushing the spinal cord and keeps damaging that spinal cord. Let us look at the natural history of the progression of the spondylotic myelopathy. Most of the patient, that is 75% of the patient, they had stepwise progression, meaning initially the myelopathy develops, then for a while, for few weeks to few months, it does not progress, and again it will progress, and after that again it will progress after a pause. So patient most of the time gets adapted to this sort of worsening of the neurology. 20% of the patient, they have slow steady progression as well. So again, this group of patient, they do not have major disability because their disability gets slowly compensated by their own way. But only 5% of the patient, they have rapid progression of the disease, and hence these are the group of the patient, they really need immediate and urgent treatment. We usually talk and teach all our patients, those who come in the OPD, this Nurick classification of disability and the gait disturbance. In the stage 1, patient will have no difficulty in walking without any tingling numbness, or may have tingling numbness which comes and goes. In the stage 2 or grade 2, there will be gait involvement but does not interfere with the employment, and patient will have persistent tingling and numbness. In stage 3, patient will have gait abnormality, patient will have significant imbalance, and patient won't be able to do his or her daily activity of living. And in stage 4, patient will be able to walk with assistance only, or may come in the wheelchair. And grade 5, patient will come wheelchair bound and will have the bladder bowel involvement. What are the poor prognostic factors? Well, age more than 60, or patient usually those who have history of smoking, those who have more than 6 months or maybe 12 months of duration. When you look at the vertebral canal and the body ratio, when it goes to less than 0.8, these are the group of patients, they will never give good outcome, and these are the patients who have constitutional narrow canal, and they are likely to have the dorsal and lumbar stenosis as well. Positive prognostic factor, larger area, shorter duration of the symptom, younger the patient, better the outcome, single level presentation, they also have good outcome. What are the strategic planning of the surgery? I think that we should really teach all the patient. We should not procrastinate. We should not ask the patient that we wait and see how you carry on. I think we should really inform the patient, talk them the warning signs, and tell them that these are the irreversible changes and will never come back to normal. On this MRI, which is on the pre-operative image, you can see that there is significant compression from C3 to C6. Post-operative MRI shows good adequate decompression. In spite of this, patient is not happy because of the poor outcome, and the poor outcome, the reason for that is the myelomalacia. The cord has got the myelomalacia changes, and that is not evident in the pre-operative MRI. So such patients, this group of patients, they are because of the long-standing compression and the changes into the nervous tissue. So the operative procedure, what to do and what not to do, will be explained by Dr. Ajay Krishnan and Dr. Ravi Ranjan Rai. Thank you for your patience hearing. Thank you.
Hello everybody, welcome to this Third Spine webinar series. Myself, Ajay Krishnan, I'll be talking on the operative and the conservative treatment for radiculopathy because of cervical degenerative disorders. Cervical radiculopathy, it's actually the compression of the cervical nerve roots which gives a complex of signs which is actually objective signs, and you have to here differentiate with the radiculitis or radicular pain, which are actually the subjective pain sensation which is radiating along the limb. These both are completely different terms. Cervical radiculopathy can include numbness to pain to reflex absences or even a motor deficit, whereas radicular pain is only the ectopic stimulation of the nerve root which may give you pain along the limb, that is radicular pain. And the incidence of a radiculopathy is in the fourth and fifth decade the highest, and typical presence is unilateral neck pain with arm pain or both, and as talked, neurological deficits can be there. The non-operative treatment we'll be talking about, as well as we'll be talking about why, when to operate, how to operate, what outcomes, what complications are expected. The best part of this disease is that though it seems to be quite dangerous and worrisome, only 5% of them need surgery. Whenever a cervical radiculopathy occurs, the goal should be to relieve pain, to prevent or treat the neurological deteriorations, improve the functionality and the quality of life, and the most important neglected part of it is that avoid chronicization and avoid the fear behavior. The patients get very fearful and they end up doing problems for themselves and the family, and they get too much dysfunctional and chronic. So that thing has to be prevented. The non-operative treatment is very much favorable, and that's what is natural history, as it is in one of the few good studies like Radhakrishnan study. 90% of patients were either asymptomatic or mildly symptomatic at 4 years, and there is substantial improvement in 4 to 6 months which remains maintained for 2 to 3 years study, which is another by Wong study which is there. These are good two papers which shows about the natural history. The medications to be given can be NSAIDs or the COX-2s, and you can use any doses which is recommended. Paracetamol, analgesics, this can be given. Centrally acting analgesics, tramadols, this can be given to the patient. Narcotics are good, but narcotics are also habit forming drugs. At the same time, they can cause a lot of constipation, respiratory depressions, especially in elderly, so have to be very careful and to be monitored. Steroids give acute relief in many of the cases, but is not to be used regularly, though many of the people use it just at the first instance itself. It should be completely avoided because steroids cause lot of other problems, and it has to be a life-saving medicine, and whenever we don't have any other choice, it should be used. Muscle relaxants, it is always controversial whether to use it or not to use it, because it controls the spasm, which is actually a protective spasm initiated by the body itself, and at the same time adds side effect like gloominess and fatigability, and at times like thiocholchicosides giving diarrheas, and also you have to be careful. Neuropathic medicines, psychotropic medicines, antidepressants medicines, sleeping pills, this all may be needed. As I talked about, the chronicization is a very common thing to occur with cervical radiculopathy or any radiculopathy, and the initial painful radicular pain is so bad in case of a soft disc that the patient may not be sleeping and keeping completely awake the whole night. So sleeping pills, don't hesitate to give them also, because if the sleep is bad, the day is going to be bad. Cervical immobilization and rest, you need collars. You can give collars, but not all collars are beneficial, because the collars are thicker on the or broader on the front aspect and the thinner on the backside velcro side. So this leads to actually a narrowing of the foramen. So foraminal disc can become very much symptomatic by wearing a collar, and the patient may completely lose a faith on you. So it is better to reverse the collar and make more space. By flexion you open up the foraminal area, and that is good. Bed rest is absolutely not needed, and the patients should be advised to carry on as much as activity is possible within pain limit. Pillows to be used, not used, all depends upon the comfort. Small pillow or large pillow. A 2-inch pillow is what we recommend to, and that should be comforted. Heat or cold therapy, what is to be used, depends upon the acuteness. In the acute phase, the ice packs and the uh, 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 does work. And in the chronicity phase, when you are gaining the moments, at that time the hot packs do work. So physical traction therapies are also recommended ways of doing it. Traction can be given, but traction, again, how it is given makes a lot of difference. If it is given in flexion, it may help. In extension, it may cause problem. So it has to be in experienced hands, and many a times the pain may increase. Fancy things like this may definitely or likely to increase the symptoms of the cervical foraminal disc or a stenosis. Mechanized devices like this are also available. These are all fancy. This can be done. There is another device which is a collar come pneumatic device which gives traction also. So this can be used for those who are not able to visit to physiotherapy or in acute phase. This may help to give a little bit of distraction, little bit of flexion. Physiotherapy is absolutely no in the acute phase, and especially these types of lateral flexions, lateral tiltings, neck rotation should be avoided completely. Physiotherapy comes into play after the acute play resolves. Isometric exercises are what is needed, and also the scapular stabilization after certain time. Rehabilitation protocol at home is needed for a longer time after the patient resolves from his acute symptoms. And ergonomics is what needs to be taught, and preventive aspect of the care is to be taught later. Manipulative therapies are very high risk are so high that it may precipitate complete quadriplegias, can precipitate vascular injuries. So it should not be done, especially in India where the chiropractic is not a registered practice. Outside India, it is still registered, regulated, controlled, and people get an MRA done, everything reported. They know a lot of things about it, and then they do certain manipulations. But in India, it is not at all regulated, and you can end up in big problems. So it should be a complete no for manipulative therapies, because here nobody even looks onto the MRI before doing such things. So it should be completely avoided. Injection therapies, the pain management injections, epidural blocks can be given to this group of patients, and it does interrupt the nociceptive inputs at the DRG level with sympathetic blocks. In some mechanical blockade clearance also it does, and IITV driven block does is good enough, but CT guided is more precise, wherein you can use in the injection. Also, something which can be used is distal nerve root block, a concept which is already there, and one of the teachers of our fraternity, Dr. Gore, it is famous as Gore spots, wherein you give blocks at the peripheral wrist level at the radial nerve block. So in that cases the pain may subside for a while, and it may interrupt the acuteness of the pain and may even help in the conservative therapy. The operative treatment is absolutely dictated and has to be offered to the patient if there is a root deficit, if there is progressive deficit, and of course if there is myelopathy, it is a treatment has to be completely directed to that level towards the operative treatment only. And a relatively offered surgery is when a shared decision is made between the patient and the surgeon. That is when there is no relief of symptoms of pain, and there is significant disability for a duration of 3 weeks, 6 weeks and more, which the patient is not able to pull on further. So they are the cases where the patient can take their own decisions in consultation with the surgeon. because it's the natural history. We all know, as we talked, it is very much wonderful. That's why we should try and not to do aggressive surgeries when not needed, and everybody follows the same rules. As I told, in our whole cases also, out of 100 only 5 is operated for a radiculopathy, so it's so less a operative rate for cervical disorders also. The approach and access to the surgery can be from the front or from the back, and the technique has to be different. So the difference are, approach is always front and back, but at the same time, but the techniques are variable with the advent of the modern surgeries, magnifications, endoscopies, MISs. There are a lot of spectrum which is there, but conventionally what we do is, for a radiculopathy, it's an anterior cervical surgery with a transverse incision for a single level disc, and this is the usual position. It's a common surgery wherein you do, and it is good because it restores the cervical lordosis. You can stabilize and fuse. Easy access is there for all the types of discs, which is central, paracentral, even oncovertebral, osteophytes, soft disc. There is no neural retraction. That is the biggest thing, which is the most important decider for outcomes in any of the neural disorders. Decompression involves removal of all the disc material anteriorly from the uncinate process to uncinate process. So from here to here, the uncinate process, complete decompression done. Anterior foraminectomy can be done good enough. The disadvantages is approach related injuries, which is going to be there. Any of these things which comes in the anterior neck can give damages, but it is seldom seen. It's not a regular thing. A small amount of dysphagia or hoarseness may occur in some patients, but all that also just gets compensated and recovers completely. So this hole can be approached from here. Anterior cervical discectomy only without fusion, that was also a recommended method of treatment few years back, but there were a 10% reoperation rate, and the reasons were the neck pain and the interscapular pain and the local kyphosis, which did occur in this group of patients. And as I told, ACDF is additionally very helpful for indirect decompression also. So if you say distract the space, you get additional space and straightening out, and even the ligamentum flavum may indirectly get stretched out, and it helps to create the space. And the outcomes are very certain and predictable. You can use bone graft, you can use cage, you can use plate, you may not use plate. This all is possible. And the most advanced of the things is the cervical arthroplasty or total disc replacement. It is a prosthetic replacement as in the knee or hip, and it maintains the motion. So that is the most important thing. And the consideration is, it also spares the adjacent segment disease, because you consider that a fusion definitely strains the adjacent segment. So by doing a disc replacement, you are definitely saving the adjacent segment also. The most recent of the reviews, which have 4 to 6 years, 8 years of outcome data, have concluded that it is definitely superior to ACDF, the fusion. And with all the outcome parameters which is there for patient satisfaction, adjacent segment degeneration, for secondary procedures numbers or implant related surgeries, neck disability index, the overall success including neurological is significantly good. And moreover, it can be combined. Say total disc replacement can be combined with ACDF, or two total disc replacement can be done together, or say one fusion and the adjacent can be done for moderate diseases. For you can do a total disc replacement, so you can have hybrid surgeries for degenerative disc disorders. At the same time, posterior access or posterior approach surgeries can be done with midline incisions or para spinal incisions, wherein you can go in, create space on the on one side only, and wherein you can do a medial facetectomy and laminotomy to create nerve root space and even remove disc. So posterior approach is possible, and posterior cervical foraminotomy is a valuable alternative to the anterior approach, and this gives you space for the nerve root foramen. So it is possible to do that, and it is specifically more indicated for soft disc for cases which needs revision surgery, and when multiple levels are affected, it would be of great help. So this is where you go in to create space for a compressive stenosis like this. And the advantages, as I told you, it's again motion preservation. Secondly, there is no implant which comes if it is a single level usually, and there is no other complications related to the approach of the anterior surgeries wherein vital tubes are going there. So posterior surgery, the only disadvantage is the discomfort and the pain for posterior surgeries, especially if it is open, is significantly high than the anterior surgery. At the same time, the cost of the surgery for posterior may be low because no implantation is there. But the literature says that 9 to 25% of reoperation rates are there, and nerve root retraction is the only thing which is a big problem for any surgeries from the posterior aspect. And you should not attempt to you should not attempt to you should not attempt to do any cord retraction in any of these patients, and any disc fragment which is lying or any stenosis which is lying lateral to the lateralmost border of the cord should only be attempted to remove this. The cervical cord is not at all forgiving as the lumbar spine, lumbar dura or lumbar nerve roots, wherein you are able to mobilize it by say half centimeter, 1 centimeter easily. So open surgeries conventionally were done with little light or normal usual lights and no magnifications, but things have changed and the disadvantages have been bigger incisions, bigger loss of blood, morbidity, bigger surgeries, mobilization was more delayed, more instabilities, more residual neck pain, and the current trend in scientific advance is preservation of soft tissue and bone. And herein comes the role of the microscopes. And here is the microscope, what microscope that comes into role, and these microscopes can be in the form of loop which is on your spectacles, or it can be externally mounted microscope which gives light as well as magnification, or it can be exoscopes which is like this, and it can be used. At the same time, endoscope is another development which is there, wherein the camera and the lens system is there incorporated inside, and it carries the working channel with the instrument and the saline for irrigation, and all things are through a Renault pen size instrument. So that is again a development. As I told and discussed that the posterior open surgeries for decompression are more morbid, and at the same time posterior percutaneous endoscopic cervical discectomy or decompression foraminotomy are good surgeries wherein you just go there and can make space lateral to the cord. This is possible by different ways, like say endoscopic, wherein like this is just a stab incision which is put, and this is the size of the dilator which is there, and this is the endoscope which you are putting there inside, and you can just localize there and get away and remove the fragment easily. The same thing can be also obtained by MIS, minimally invasive spine surgery, tubular posterior foraminotomy. This again is another way of doing it. This again is another way of doing it, wherein you would you would put a small guide wire and then dilators on it, and after the dilators are put there, you fix the tube there, and once the tube is fixed, it is used as the channel to do a microscopic surgery. And this is the view what you have, and you can just remove the fragment there in the foraminal area lateral to the cord. You cannot retract this cord. That is the most important thing what we all have to remember. At the same time, similar to what is the posterior percutaneous endoscopic cervical discectomy or decompression possible, anteriorly also it is possible, but this is with a very smaller scope, half the size of the posterior scope which is there. This is very small. It can go through the vertebral body or through the disc and directly approach the foramen, because you are not removing the entirety of the disc, you are not fusing also, you don't need to, you can just remove that part of the disc fragment and come out. It can even be done under local anesthesia at some centers. The post-operative management, hardly any bed rest is there for any deficits which is not there, or say upper limb deficit is fine. For myelopathy, the patient has to respond to the treatment, and then only you can mobilize, which will be covered in the later part of the talk. Mobilization is so quick, and climbing stairs and things are fast allowed, including bending. Sports, non-contact sports, jerks and rotation should be avoided definitely. So to get back to work, it's early. So sorry, for non you can go for non-contact sports, but contact sports should be avoided. To get back to work, you can get early, 2 to 3 weeks you can get back to work. Exercises, small exercises, you are starting by say 3 weeks to 4 weeks. And the most important thing is the preventive maintenance, the ergonomics, which you have to take care so that you don't have any other disc problem soon. Is it really so easy? Pitfalls and complications are also there as for any treatment, any surgery. And the complications of surgical things are failure to relieve the symptoms, level failures can be there, neurological deficits can occur, infection can occur, instability can occur, iatrogenic injury can occur, paralysis can occur. But these are all nearly nil. We do so much number of cases, and it is hardly we are seeing any complications in the routine. We don't see complications. Non-relief of symptoms or moderate relief of symptoms in myelopathy is expected, as will be discussed in the following talks. But for radicular pain, even deficits, they recover significantly and faster and quicker if done timely. So reconstruction options, that's the way what we do. Is after a discectomy, we can put a case there and a plate there to reconstitute. We can save money by putting a bone graft and accept the morbidities of a tricortical bone graft from iliac crest. Static thing other we can do is 0p. This is cage cum screws built-in device, which is a synthesis device, and it helps in lesser dissection. And the dissection, because of the dissection, usually for the plate you have to encroach to the near end plates of the upper and lower level, which can be completely avoided in this device, which is 0p. Dynamic stabilization device, as we talked about total disc replacement, at the same time there is something this called DCI that also allows certain degree of movement, and it's a cheaper alternative than the total disc replacement. And this is disc replacement which we do. You can see in both cases, you can see the spinous process opening up, and you can see the movement which is noticed. 90 to 95% of cases can be conservatively managed, so there is nothing to be worried on that. And a decision for all pathologies, we can do an anterior workhorse approach, except for multi-level disease wherein you have to go in posteriorly. Posteriorly only for facetal arthritis and for soft lateral disc, it's a good option if minimally invasive approaches are followed. So the workhorse approach is anterior only, but with minimal excess advent, it is going the posterior way again, endoscopic and minimal invasive surgeries. Thank you very much.
A very good evening to everyone. I am Dr. Ravi Ranjan Rai. Taking the discussion forward, we'll be talking about treatment of cervical spine stenosis. So, treatment of cervical spine stenosis can be summarized as conservative or surgical. Conservative treatment comprises of rest, medications, and physiotherapy. As Bharat sir has discussed, cervical spine stenosis can present either as axial neck pain, in which most of the cases can be treated without surgery, or radiculopathy, where few people may need surgery. We have discussed the treatment of radiculopathy, uh, or can present as myelopathy, in which case surgery is a must. When surgery is required, it may be anterior or posterior surgery. We have Ajay sir has talked extensively about different ways of anterior surgery. I would only like to add that in case of stenosis, when we operate, we see it is usually more extensive decompression that is required, because we are most of the cases operating for myelopathy, and we often the patient present with multi-level disease. Okay, so we'll see one more case example. Here is a 55-year-old gentleman who presented with gradual onset numbness of right upper limb and lower limb along with imbalance on walking fast or on running. Imbalance of gait has been there for 1 month. Commonly, imbalance is or slipping out of the slippers is the first presenting complaint in cases of myelopathy due to cervical spine stenosis. So this patient complains of needing support for walking, and he was not able to stand or walk independently for the last 3 days. Along with that, he also complained of loss of dexterity. Patients usually say that my handwriting has changed or the signature that I do in my bank has changed. The bank doesn't recognize my signature anymore. So these are all signs of myelopathy. As we see in this patient, the compression has been there from anterior. However, whether to do an anterior or a posterior surgery depends on a number of things. But before venturing into the surgery, what is required to understand and to explain to the patient is that the neurological recovery is unpredictable irrespective of surgical intervention. That is, we cannot predict whether whatever neurology has been lost will be recovered completely or maybe 10% or 50% or may not recover. Second thing is how much time it will take to recover. We do not have an exact answer to these questions. Another thing which the patient must be made to understand is that there is a risk of further neurological damage during the surgery, because as we have seen many times, the patient may come with partial neurological deficit, but he is at the verge of just increasing neurological deficit, and our surgery just pushes it. So the risk of neurological deficit is real, although it depends on the extent of compression as well as the duration of symptoms. And in spite of this unpredictability, there are a few factors based on which we can provide some prognosis, like the age. Lesser the age, better the prognosis. Duration of symptoms, longer the duration of symptoms, worse is the prognosis, as well as the Nurick grade. Nurick grading tells us about the severity of compression as well as the severity of the extent of neurological involvement. Those presenting with Nurick grade 5, that is those patients who are not able to stand or walk without support, will have worse prognosis as compared to those presenting with Nurick grade 2 or 3. These are early phases of Nurick grade where the patient is still able to walk and manage with slight imbalance. So this patient that we showed, we operated with a cervical laminectomy. Cervical laminectomy is cutting and removing of the lamina in order to open up this space for the cervical spinal cord. And as we can see here, this works by indirect decompression. That is, once this lamina are removed, because the cervical spine is in lordosis, the cord falls back and we can see CSF space both anterior and posterior to the cord, which shows adequate decompression. In cases of kyphosis up to 13° or kyphosis which is correctable to neutral or lordosis, we may add a fusion in the form of lateral mass fixation or pedicle screw fixation. Sometimes we come across these challenging cases which need both anterior plus posterior fixation. This is an era of technology. So this is what we have latest in cervical spine surgery, that is the ultrasonic bone scalpel. This is a bone cutting scalpel which cuts the bone through ultrasonic energy. It provides precise cutting, and this is an example where the patient presented with extensive anterior compression with OPLL. We were able to manage this case smoothly because of this instrument, and this is one instrument which has extensively changed the practice of cervical surgery. This is another case example where the patient presented with not only cervical stenosis and compression but multi-level thoracic compression as well, and we were able to do so many level laminectomy. It was possible only because of this one instrument, ultrasonic bone scalpel. We have a few articles in literature as well from our institute on ultrasonic bone scalpel. This was a landmark paper in European Spine Journal. This was a study of 101 patients where anterior cervical corpectomy was done using ultrasonic scalpel. Another publication appeared in Global Spine Journal 2019, where we presented a study of 311 patients where cervical laminectomy was done using this instrument. Another instrument which has extensively changed our practice is the O-arm. This is an intraoperative CT scan machine, and this is linked to navigation tool. That is, this extensively increases the accuracy of the screws that we want to put. Cervical pedicle screw, that is from C3 to C6, is the most difficult thing to put. It has a very narrow corridor of around 3.5 to 4 mm, in which we have to put a 3.5 mm screw. We all know there are essential structures around it, the vertebral artery, the spinal nerves, which can get damaged in case of any minor error. The presence of navigation and O-arm has provided us with that increased accuracy and has significantly reduced the complication rate and increased our confidence. So as we all know, Socrates gave us the slogan, first do no harm, do good. Now with latest technology, we can say that we need to do the best, and that is what we strive to do here at Stavya all the time. Thank you so much.
Hello everyone, my name is Virju Vyas. Tension neck syndrome occurs in people who has a tendency to walk with the forwarded posture. Some muscles get tight and some muscles get weak, and that is what imbalance. It causes tension neck syndrome. Normally, when the head is sitting on the spine, the weight is around 4.5 kg for the neck muscles. As we look down, we go for flexion. At 15 degree of flexion, the muscle carries around 12 kg of load. And more we look down around 60 degree, the muscle carries around 27 kg of load. So the neck muscle get fatigued if we look continuously down. So activities like using mobile or some other activities lead to such stress on a muscle, and that is painful. Activities like cooking, looking down, chopping the vegetables leads to continuous stress on the neck. Mobile, using the laptop for long hours, even knitting the clothes, operating for surgeons, even the medicos are also involved. Whoever dentists, they also have to look down and continuously walk. So such postures are very painful because the muscle gets fatigued. Continuously being in such postures lead to tightening of upper trapezius and tightening, that is shortening of pectoral muscles. So the posture goes like this, where the neck muscle, the extensor or trapezius muscles get shortened and pectorals get shortened, whereas the deep neck flexor muscles and interscapular muscles, they become more and more weak. So the goal of the treatment should be first stretch the tight muscle, that is trapezius, and stretch the pectoral muscles, whereas the strengthening of weak interscapular muscle and weak deep neck flexor muscles. So let us see what exercises should be done for that. The first exercise will be for the trapezius. We do the stretching. We keep the hand gently on the head. We look down, and then that is how we stretch the trapezius muscle of neck. Such postures can be maintained for 5 seconds and then release again. And again you can do the same posture for 5 seconds and then release again. And such repetition can be done for 5 times. Gradually you can increase the holding time from 5 seconds to 30 seconds also, according to the comfort limit. Now the second stretching is for the pectoral muscle, where one should start with the standing posture because it is more comfortable, and then take the chest out and take the hands back, and that is how you can stretch your pectoral muscle. And the same thing can be done with a corner, where you can stand with the arms on the sides and move forward with the arms on the wall, and that is how you can stretch your pectoral muscle, and then release. The repetition will be same, 5 counts hold, maybe 5 seconds, and repeat for 5 times, gradually to 10 times, and hold can be increased to 30 seconds. So till now we saw stretching exercises, and now we move on to strengthening exercises. Strengthening of deep neck flexor muscles can be done like this, where you have to take the head forward and then you take the head backward like this. So when you take the head backward, your voice will be changed. Again, you can see when you take the head forward, the voice is different, and when you take your head backward, the voice will be different. So this is actually a right way to do the exercises, and you can confirm that the exercises are being done in right posture and right position. So the ideally when we do the full day activity like this, it is good to keep the head like this for a while. Again, do it for maybe hold for 10 counts and then release and repeat for 10 times. As this is a strengthening exercises, the holding time should not be more than 5 seconds. The way you do it in stretching, where you can increase the holding time to 30 seconds, it should not be done in same case. Now this exercise is for strengthening the rhomboids and lower trapezius muscle. It can be done nicely with the retraction of the shoulder, where one has to take the chest out and squeeze the shoulder blade muscles. So one can do the same exercise with the prone lying, arms on the side, and then abduct and take your arms backward, which will strengthen the interscapular muscle. And again hold for 5 seconds or maybe 10 counts and then release. Again do it for 5 counts, 5 seconds and 10 counts, and then again release. You may do the same repetition for 10 times and do it twice in a day. Exercises if done twice in a day gives good result. So these are the short list of all 5 exercises can be done for somebody who has to work whole day in a forward head posture. Let us discuss some important points to know about exercises, physiotherapy. So whenever doing the exercises, pain should be the alarm criteria. If the exercises increases the pain, that is not good. So either you can reduce the count, you can reduce the repetition, you can reduce the weight, and you may not do it at all. The second thing to remember is choose specific muscles. More often what we do, we treat each and every muscle of our body during the workout. So rather no, you should not do same exercise in same amount for all muscles. The muscles should be chosen according to their use. Like more often, for example, more often we walk in the forward position or maybe in the front. So what happens, the front muscles are tight, so you need to stretch it rather than strengthening it more and more. And what you can do, you can strengthen the back muscle, that is interscapular muscle more, so the muscle gets strength. The reverse should be done in a case of lower back, that is tummy. So strengthen your abdomen muscle and stretch your back muscles. So this is how the exercises should be done. Exercise can be done twice a day, which is having it is proved that it has a good effect. Exercises should be done lifelong, continuous. Exercises can be done 10 times in one set, and gradually you can increase the set to 2 and 3. And exercise can be done like strengthening can be done 10 times, where stretching should be done 5 times only. Stretching should have a long hold period, whereas the strengthening exercises should not have the long holding period. Thank you.
Good evening. I welcome all viewers again. I am Dr. Shivanand Mai. Today quickly I am going to refresh your knowledge about certain conditions which mimic the pain of cervical spine. ऐसे कंडीशन हैं जो cervical spine pain का अनुकरण या नकल करते हैं. So nothing to declare, financial conflict nil. Coming to the mimickers of cervical radiculopathy pain, mainly these are the certain musculoskeletal conditions which we usually see in general practice or orthopedic practice, which mimic the pain of cervical spine pathology and confuse the treating physician. So most common are the shoulder, elbow and wrist disorders. So mainly the rotator cuff disorders, rotator cuff tear, calcific tendonitis, biceps tendonitis, osteoarthritis of the shoulder, glenohumeral joint instability, subacromial bursitis, and impingement syndrome. So this pain can radiate along the anterior part of the shoulder or along the posterior part of the shoulder. So you all know there are many tests to diagnose this condition like MTCAN sign, NEAR sign, others, so which could be differentiated with the cervical pain with this specific test. Come to the other condition, that is adhesive capsulitis, which is seen in elderly people, mainly in diabetic patients. Sometimes pain will be very severe, radiating all towards elbow and towards neck. So this also needs to be differentiated from the cervical pain. As you know, tennis elbow or lateral epicondylitis, sometimes patient comes with severe pain with history of radiating up to the wrist and fingers. So it can be diagnosed with specific tests like Cogen's test and treated appropriately. And tenosynovitis conditions like decurrence tenosynovitis with Finkelstein's test, it can be diagnosed and differentiated from the cervical pain. Acute brachial plexus injury or viral neuritis of the brachial plexus sometimes mimics the pain of the cervical spine, which should be kept in mind. And the peripheral entrapment neuropathies like cubital tunnel syndrome, compression of the posterior interosseous nerve or compression of the median nerve at the wrist, which can be diagnosed with Phalen's test or Tinel's sign. The other condition is thoracic outlet syndrome, where the brachial plexus structures and nerves which go beneath the clavicle and coracoid process are compressed at the thoracic outlets, and the cervical rib also adds to this one. When specifically when patient is abducting his upper limb, so patient will feel tingling and numbness. So with specific tests, this can be differentiated with the cervical pathology pain. Next condition is the visceral organ diseases. So visceral organs from the thoracic cavity, abdominal cavity and pelvic cavity gives rise to radiating pain. Sometimes some organs pain radiates to around the neck, which confuses with the cervical pain, like liver and gallbladder pain gets radiated to the neck region. Lung and diaphragm pain also get radiated to the neck region, which can confuse us with the cervical pain. And as we all know, the ischemic heart disease, angina pectoris, where the pain can radiate towards the base of the skull and the chest, shoulder, medial aspect of the arm, forearm up to the medial finger. So this is the pain which is also seen in the cervical spine pathology. So we need to take the history in detail and go for other specific investigation to differentiate between these conditions. Other most common condition is fibromyositis or fibromyalgia, which is seen in females, and we know that these are the described tender points where patients usually complain of the pain. So with this specific history, we can rule out this condition and differentiate from the cervical spine pathology. Coming to the mimickers of cervical spondylitic myelopathy. Myelopathy, as we know, the main complaints will be instability, walking difficulties, imbalance. Okay. So the differential diagnoses are mainly peripheral polyneuropathy, diabetes mellitus, and other conditions, motor neuron diseases, multiple sclerosis, cerebrovascular diseases, and syringomyelia. So the main complaints will be pricking sensation, eyes cold sensation, burning sensation, and numbness. Coming to the causes of myelopathy, there is the big list of causes of myelopathy which needs to be differentiated from cervical spondylitic myelopathy, like trauma, multiple sclerosis, vascular disease of the spinal cord because of atherosclerosis, rheumatoid arthritis, and other conditions like ulcerative colitis, paraneoplastic syndrome, myelopathy, metabolic conditions like deficiency of vitamin B12, copper deficiency, chronic liver disease, hyperparathyroidism and hyperthyroidism, or previous radiation therapy, electrical injury. These are Friedreich's ataxia. These are all the other conditions which require special attention before planning the treatment. With this, I want to conclude my talk, and I request our viewers to be online for the question and answer session. Thank you.
Good evening. I have the opportunity to summarize the cervical disc disease. The central neck pain in the young population, most of the time it is observed that it is because of the bad posture and particularly related to the computer workers. Exercise and neck care is the ideal treatment. We really need to give them the time to understand the ergonomics, and by doing that, the neck pain can be resolved completely. In the elderly, we know that degeneration takes over, and because of the facial arthritis, disc degeneration, they get the central neck pain. And for that, treatment is rest, collar, and exercise. But we should also rule out the causes that can cause central neck pain as well. Radiculopathy is common in both the age group. Natural history of radiculopathy is favorable, and one may say that it is self-limiting to a great extent. This soft disc is seen in the young age, and conservative treatment, 90% plus cases, it works for them. Surgery is indicated for neurological deficit like biceps, triceps, or deltoid weakness. But the hard disk is seen in the elderly, and patient may not respond, and surgery is indicated for excruciating pain and failed conservative treatment trial in the form of injections and all that. What are the non-operative management? Usually we give combination of non-steroidal anti-inflammatory drugs, gabapentin, pregabalin, occasionally oral steroid can be given. Cervical collar can be given for the rest, neck. Intermittent bed rest, traction can be given as well. Acupuncture and physiotherapy, they remain the mainstay in the non-operative treatment, and once the disc degeneration has taken place, patient has radicular pain and they have responded, we advise them to continue exercise for the lifetime. Myelopathy, loss of dexterity. Patient most of the time complains that he or she is not able to eat properly and the signature in the bank gets rejected. And closing the eyes with keeping feet together, that's a Romberg sign. If they say side by side, these are the early signs of myelopathy, and those things should not be ignored. It is not self-limiting. One must remember that myelopathy is not self-limiting. Degeneration is most common cause and surgery is required. One may say that myelopathy is a surgical disease. Disability increases if it is ignored. Early surgery gives a better outcome and late surgery gives a poor outcome. Smokers, diabetes, all those things, they also add into the negative effect of the myelopathy outcome. So take home message for the myelopathy. I think we all should make this worldwide awareness of degenerative cervical myelopathy, because treatment given in time improves the neurological function and certainly improves the quality of life. And in the long run, if you put it as, it is certainly cost effective as well. So future direction should be increase the awareness of degenerative cervical myelopathy. Optimal management should be carried out considering to the patient's age, and neuroprotective and neurodegenerative strategies has to be applied in the form of gabapentin and rest and other medications that reduces the vitamin E, that reduces the overall antioxidants. Thank you for your patience hearing. Thank you.
Yeah, I welcome all viewers
of this webinar. So I thank you all speakers for elaborative talk today. So we will start with the question answer session. First, I would request Dr. Bharat Dave sir, Senior Spine Surgeon from Stavya Spine Hospital, to start with question answer session. The question for sir is, sir, what the audience want to know, what are the indications for the disc replacement in the cervical spine pathology, and whether the disc replacement is a lifelong, this one device, its function lasts for lifelong?
Yeah, I think that's a good question. Disc replacement can be done for single level either radiculopathy, pain in the arm, or the single level myelopathy that can be used. And this basically is a motion preservation technology, and it helps to preserve the motion, and it helps to avoid the adjacent level degeneration. The results are out of the the literature says about 10 years good outcome, and so it is not a lifelong, because we do not have the results more than 10 years. Some papers they have come out with 15 years, but I think we really need to confirm that. So in our center, we are happy to announce that we have been using this device since maybe more than 10 years, and our success rate has been about 70 to 80%. They have still the movement which is preserved at the end of 10 years.
Okay. Thank you, sir. So I would request Dr. Ajay Krishnan sir, who is expert in endoscopic surgeries at Stavya Spine Hospital. Sir, what are the benefits of endoscopic surgeries over open surgeries for the patients?
The endoscopic surgeries are surgeries which access related injuries, the lesser footings are left. As of now, for cervical spine, soft disc prolapses are well managed by posterior percutaneous ACD, posterior percutaneous endoscopy. They work very well. Stenosis, which is bony, there also it works very fine, because in these both conditions, when you are doing an anterior surgery, what you are traditionally or conventionally doing is you are doing an ACDF, where you open up, remove the disc, you are able to decompress it. At the same time, you jack up the disc, distract it, and get that space and fuse joint. So the loss is fusion of the joint. The surgery for collapses are typically managed surgeries for families to know any of the major problems, and for those who are doing it on a regular, it should decompress it of the joint. The surgery is not that concerned for those who are doing it of soreness. Otherwise, there is no complaint. But
Thank you, sir. So next
posterior
question.
spine, soft open surgeries are collapses are very open surgeries are quite morbid, and economy also. So,
Okay. Thank you, sir. Now I would request Dr. Devanand to answer this question. Dr. M.M. Dholakia from Junagadh is asking, which group of people gets early degenerative cervical spondylitis? Is it the hard workers or the constant computer office workaholic people who get this cervical pathology?
Yes. Good evening, Dholakia sir. That's a very interesting question. As per the literature goes, we have a lot of literature from West, which says that computer workers, software professionals, when they are in improper position while working for longer duration and longer time, they have chances of cervical spondylosis. But we do not have Indian literature as of now, and we do not have literature of people who are carrying heavy weights on their neck, except for we have done a study at our Stavya Institute and we have published it, where we have studied people, especially from Rajasthan and Gujarat, where they are carrying heavy loads on their head. And these people, group of people, have early arthritis and especially C12 arthritis. So the topmost joint of C12 has some sort of arthritis in these cases. So as of now, we are not clear workaholics or software professionals are they get more of spondylosis, but yes, they are at risk. Thank you.
Yeah, thank you. I would like to ask Dr. Ravi Ranjan Rai, our team member, surgical team member from Stavya Spine Institute, to answer a question from Dr. Ratish from Malappuram, Kerala. He wants to know that how do you manage patients only presenting with interscapular pain?
Good evening, everyone. Yeah, that's an interesting question. Interscapular pain presentation more or less goes into the sort of management that we offer for axial neck pain. However, this needs to be evaluated in detail. There may be other causes of interscapular pain apart from discogenic pain. So, if the symptoms do not exactly match, or if there is any clinico-radiological mismatch between the presenting symptoms and the MRI, other causes of interscapular pain needs to be ruled out, like esophageal problems or aneurysm of the aorta.
Thank you.
But if everything else is ruled out, it is more or less similar to axial neck pain, management of axial neck pain.
Thank you, Dr. Ravi. So now I would request Dr. Birju Vyas, Birju Bhai, ki how long we should advise exercises to the patient? Neck
Yeah,
exercise. Yeah.
yeah. Exercise should be done as long as possible. We usually advise to do the exercises for lifelong. More often, patients cannot be, they cannot do it for a long time, but at least I will advise to do it for 6 months or 1 year. Till the end, they can do.
Okay.
And then they should reduce the exercise, but probably they should not stop the exercises.
Okay. Thank you. So I would like to ask Dr. Bharat Dave sir. Sir, what are the complications associated with cervical spine surgery? And with latest technology, how do you perform safe spine surgery, preventing all these complications?
Yeah, I think this is the time to really sort of highlight, and we really should mention this. We have this enabling technology. We have the O-arm and navigation in our operation theater along with the neuromonitoring and the bone scalpel. That makes the integrated theater suite. So all these four technologies put together, we have performed about 60 odd C1, C2 surgeries without any mishappen. Meaning this enabling technology has made the cervical spine surgery pretty safe. But yes, nothing is foolproof and nobody can say 100%. But previously when we were operating, this sort of cases, which are the high-end cases which can go wrong at any stage, we have had problems. And we will really miss a heartbeat if I really tell you from the surgeon's perspective while doing such case if something goes wrong. And these things have not gone wrong in the recent last 2-3 years, 2.5 years, since we have adopted these technological advances. So that makes the cervical spine surgery quite safe because at one end we have vertebral artery, at one end we have the esophagus and the vital structures, and at the other end we have the spinal cord. So we have real small corridor to put these screws to stabilize the spinal column. So it's a good thing, to adopt some technological advances and give this safe surgery to our patients who really needs this, and these are the high-end cases.
Thank you, sir. So I would request Dr. Ajay Krishnan sir to answer about does the neck range of movements of patients will be same after surgery as a normal person?
This is in which surgery? Sorry.
Any surgery, sir, any cervical pathology surgery, the viewer want to know whether the range of movements of the neck will be same.
Yeah, the range of movement of the neck for any of the surgeries of fusion, which is a single segment fusion, that is one disc level fusion, what you do, you will lose a movement of say 10% roughly. But at the same time, what happens is that when you are losing the movement by 10% at one segment, that 10% is easily compensated by other joints which are adjacent and subjacent, which gives the added mobility. So frankly speaking, there are no big losses to this fused patients also. It's very nominal. But the excess strain which is going on at the adjacent levels definitely adds to adjacent segment diseases, and that's why the most novice innovation has come into play for preventing of adjacent segment diseases, that is cervical disc replacement or total disc replacement, wherein you retain that movement. So you practically lose not much of movement whenever you are using disc replacement or endoscopic surgeries. But yes, for fusion in multiple level, you definitely lose it.
Okay, thank you, sir. So I would like Dr. Devanand. I request Dr. Devanand to tell something about what is the time period before we should advise surgery to our with any cervical pathology.
Yes. It's basically a long question for me. I would like to answer short. Cervical pathologies range from cervical disc prolapse to cervical stenosis with myelopathy, as Dr. Bharat has discussed. Cervical disc prolapse patients are usually managed conservatively. Most of the times they recover. I would say only 5% of the patients are advised surgery after 6 to 8 weeks of conservative management. If the patient has only radiculopathy, no any other signs of weakness. But yes, if the patient has cervical myelopathy and they have weakness, imbalance while walking, we would explain them as early as possible to get the surgery done so that we stop the progression, so that the patient doesn't deteriorate further. If they deteriorate further, per se, they have coming bedridden or wheelchair bound. Even if we do the surgery, they are not going to get better. So the surgery is advised to the patient based upon the clinico-radiological correlation and symptoms as well as MRI findings. Thank you.
Okay, thank you. I would like to request Dr. Ravi to tell something about, does this cervical spondylitic myelopathy patients require urgent surgery? Any emergency conditions where they should undergo urgent surgery?
Yeah, thank you for the question. So, development and progression of myelopathy itself is an indication for surgery as early as possible. As far as the urgency of the situation is concerned, it will depend on how fast the progression is and what are the vital nerves that it is affecting. For example, if it has affected the bowel and bladder, the situation is really urgent. If it has only affected mild imbalance, some patients do maintain stable neurology for a long time even after starting with the development of myelopathy. So in these cases, it may not be urgent, while on the other side of the spectrum, we have patients who over a short period of time develop rapidly progressive neurological deficit, including bowel bladder. These are cases which should be dealt urgently.
Okay, thank you. I would like to request Dr. Birju Bhai to cervical traction. How much you give, how long you give, and what is your experience about patients this relief of pain?
Yes, sir. Cervical traction, nowadays what we use is called as a decompression system, kind of a cervical traction, which increases the traction force very gradually. So more often it doesn't increase the pain. And the best thing what we can do in that is we can give the traction in flexion position of the cervical spine. We usually give traction maximum for maybe 10 sittings. And if the day one the pain increases, then we advise the patient to stop the traction, and that is how we give it.
Okay, thank you.
Yes.
Now I like to request Dr. Bharat Dave sir to throw some light on how often you come across the mimickers of cervical spine, sir, and how do you convince your patients about the other conditions which give rise to this cervical pathology like pain?
Quite frequently, we do see overlapping pathology. And as you have correctly mentioned in your presentation, that there are so many pathologies that mimics the cervical syndrome as well, cervical spine problem as well. So we do see quite frequently, and at our center we have sort of three checks. So we really have one consultant seeing the patient, second one, and then probably the our physio team has also evaluates the patient as well. And we also have the gamuts of investigations we patient goes through. So in order to have sort of tertiary care center in the spinal disorder, we certainly take care and we certainly look at all the other causes of the cervical spine. And if at all, if I have to really figure out, what sort of percentage, I would say maybe 20% or even more patient, they have the mimicking cervical disorder as well. So this is something that we have to keep it in mind when we treat such patients as well.
Thank you, sir. So I thank you all the viewers and today's speakers. So, and I request Dr. Bharat Dave sir to say some conclusive remarks for this.
Yeah, thank you all the viewers. I think you have been either physically present or you have been watching our video after we have completed the webinar, and we do get viewers in more than 4 figures. So maybe 1000 plus viewers, we do get it. We continue to have the same sort of webinar for the enabling technology and the advances in the spine surgery is the next webinar. And afterwards, we also are planning to have the ankylosing spondylitis, because we have a large number of patients who suffer from ankylosing spondylitis. And there are various newer drugs which are available. And we really are passionate about the osteoporosis and ankylosing spondylitis. These two conditions which affect spine and certainly disables the individual. And in particularly ankylosing also disables the young population. So these two next webinars are lined up. So please do join us in the webinar, which is going to be the next webinar, which is going to be on the advances in the spine surgery. I thanks Torrent to sort of give us the continuous support and to reach you all viewers. And our videos are available on the YouTube. Please do watch and give your feedback as well. Thank you very much. Over to Shreya, please.
Thank you so much, sir, and thank you so much to all our wonderful speakers today for these wonderful sessions. Thank you to all the live audience today for joining us. The topic today was cervical degenerative disease. The knowledge karwa shall continue as just mentioned by Dr. Bharat Dave. These recordings are live and available on YouTube, and we shall also be circulating the link to all of you post the webinar. You all can subscribe to Survey channel on YouTube and Facebook page for regular live updates. Survey team is doing a lot of programs related to patient education as well. Today was the 4th webinar of the series. The 5th webinar, please mark your date, is on 8th October at the same time, that is 7 p.m. onwards. The topic would be advances in spine surgery. Shelcal, his immense gratitude. A warm thank you to you also, Dr. Birju Vyas, for joining us today. Thank you, Dr. Shivanand, for the wonderful hosting, Dr. Bharat Dave, Dr. Ajay, Dr. Devanand, and Dr. Ravi Ranjan. It has been such an honor to have you all with us. Good night to all. Stay safe.
Thank you. Thank you very much. Thank you.